All right. This is a chapter where we're going to talk about protecting yourself, particularly as it relates to lifting and moving. And one of the more common injuries that ends a EMT's career is a back injury. Um, so the proper use of your body to prevent back injuries and also help you facilitate lifting and moving patients is important to discuss as well as practice. So in addition to talking about it in these chapters, you're going to have opportunities to practice lifting and moving as part of your skill set. So we're going to consider the following before lifting any patient. How much do they weigh? And whether you need additional help to lift. It's not uncommon in many communities, whether they um, it's just not uncommon in many communities that you rely on the fire department for lift assist. If as a responder, you and your partner are unable to lift or move a patient because of their size, then you'll need that additional help in order to help lift them. Know what your limitations are. If you exceed them, you're going to hurt yourself, plain and simple. Know what you can lift comfortably, and we'll talk about ways to lift more efficiently as well. It's important that as an EMS provider that you and your partner or you and whoever's doing the lift have a plan and communicate that so that you typically move in one swift motion rather than maybe one person starting to lift while the others aren't, and that one person then has to lift all the weight and can wrench or hurt their back. So it's important that you identify who's going to do the count, and that you all lift on three, and then you do the lift. It's really important to position your feet properly. In other words, feet shoulder width apart. Give yourself a good base. You want to lift with the most strongest part of your body, and that's your thigh muscles. Um, it says never turn or twist, and that is so hard to do in EMS because when you're in a ditch and you're moving from one side or the other, whether it's handling equipment or actually moving a patient. It's very tempting just to turn or twist. But try to keep that in mind to avoid that if possible, because that's where back injuries occur as well. Um, and do not compensate when lifting with one hand. You shouldn't be lifting with one hand. You should be using both hands, particularly anytime you lift a patient. Keep the weight as close to you as possible, so get as close to the cot or as close as you can. I know there are going to be times where if you're sliding a patient over from the ambulance cot to the ED stretcher, that you might have to extend yourself, but realize that every time you do that, you increase your risk of hurting your back. If at all possible, use a stair chair when carrying a patient downstairs, and most of them are the newer ones, if you have them, are developed to where it's much like a refrigerator dolly. It's got a nice rubber track on the back that just gently goes from one stair to the other, and you can carry a lot of weight with a stair chair without hurting yourself. So here's an example of a stair chair and the proper lifting technique where the weight of the patient is as close to you as possible. You have a spotter on behind the person backing down the steps to assure that they don't fall. The power lift is important because that's going to give you the most strongest grip. You see how the hands are turned upward and grasping the cot. The back is relatively straight, the knees are bent, and he's going to use his leg muscles to stand up. If you don't have that grip like it's shown here, there's a potential for the cot, the stretcher, whatever it is you're trying to lift, slips out of your hand. When reaching, keep your back in a locked position. Try not to twist. Avoid reaching more than 20 inches in front of your body, and then avoid prolonged reaching when you're doing strenuous lifting, because, again, it just really increases your risk of a back injury. You should push rather than pull whenever possible. You should remember to keep your back as straight as you can, keep it locked, keep the line of pull through the center of the body, and this refers to moving them along spine board as well, and then keep the weight as close to your body as you can. If the weight is below your waist, push or pull from a kneeling position. Avoid pushing or pulling overhead. That's where you get rotator cuff tears. Keep your elbows bent and your arms close to your side when lifting. We're going to look at some emergency, urgent, and non-urgent moves that you may use. Now, emergency moves are for when you're dealing with a hazardous scene. The car's on fire. The patient has a life-threatening condition. The patient's in a car and isn't breathing. Or the patient is deceased, and you need to get to somebody else in the vehicle. One emergency move that you can do is a clothes drag. Just grab them by the clothes and drag them across the floor. Another one is an incline drag. Now, of course, here you're resting the weight of the patient's upper body on your leg as you're backing down the stairs. The issue is, he's not going to be dragging his butt boom, boom, boom down the steps, but he certainly will with his feet. Here's a firefighter's drag where you can use your cravat to tie the patient's wrists together, slide in under his tied wrists, and then just drag him as you crawl across the floor. Here's a blanket drag, again, putting him in a blanket and using the blanket to drag him across the floor. Here's a one rescuer assist, and again, you should be able to practice these different emergency moves in class when you do your clinicals. Here's a two rescuer assist, and essentially each rescuer becomes a leg for that patient. Urgent moves, these are situations that require treatment that can be performed only if the patient is moved. And then the factors at the scene may cause a patient to decline. If you, again, fire, smoke, fumes, those sort of things, you may need to move the patient in order to provide care. Moving a patient onto a long spine board, there's been so much information concerning whether or not we should be putting people on hard boards. And the National Association of EMS Physicians published a statement in 2012 that said we shouldn't be using hard boards at all. And if we do, we should use them maybe to move a patient from point A to point B and then take them off the board, regardless of their problem. But they still are a mainstay in EMS care and slowly going away. Scoop stretchers are a better alternative. Vacuum mattresses are a better alternative. But you'll learn how to put a patient on a long spine board. In fact, it's one of your National Registry testing stations. How to log roll a patient, to put them on a long spine board, and that's come under fire as well. We talked earlier about some research, and research has really shown that, in services who quit log rolling their patients, saw a 30% improvement in mortality. So 30% less people died, especially those with major pelvic trauma, by not log rolling them, just scooping them up and putting them on a cot. Again, you can use that long spine board to move a patient from point A to point B, but then take them off. Rapid extrication is another skill that's really come under fire of late. It's used when taking time to immobilize a patient with a short board or a KED. It just takes too long. So if I have a patient who's critically injured and needs to be taken out of a vehicle quickly, we'll use the rapid extrication technique. The problem is that it's supposed to be used only when a patient has a life-threatening injury, and delaying their extrication would be or could be detrimental to their life. Unfortunately, it's just used on everybody, so it's overused and is not a real efficient method of of getting them out of a vehicle. And in your practicals, you'll work on rapid extrication and the different techniques involved to rapidly extricate. Non-urgent moves are used when the patient is stable, there's no life threat, the patient can be assessed and treated right where they are, and then take all the required precautions prior to moving them as well. Stretchers or any other devices are designed to carry the patient safely to the ambulance and or to the hospital. We have wheeled stretchers, we have power cots, we have manual cots, we have bariatric cots. Most cots today are rated to carry patients up to 750 pounds. Bariatric stretchers are rated to carry patients weighing 800 pounds or more. So here's an example of a cot. Looks like perhaps it's a power lift. It's got a control box there on the back side. So when the front wheels are placed into the ambulance, the button is pushed, the legs come up, and the cot is slid into the ambulance. There's a Furno power stretcher. Again, two types, Stryker and Furno, are two of the major cot manufacturers in the EMS industry. Now here's a bariatric lift where you've got a track and the patient is placed on a bariatric stretcher on the track. And then either pulled, here they're pulling the patient into the back of the ambulance. Some of the new ambulances have self-loading cots where you bring them up to the back of the ambulance, you hook them onto a track, and they're pulled right into the back of the ambulance without anybody having to lift anything. Stair chairs are very useful when you have to get people downstairs. Short spine boards, particularly the KED, the Kendrick extrication device, are used primarily for immobilizing the neck and the back when moving somebody out of a vehicle. But you can use a KED in a person who perhaps has neck and back pain following a motor vehicle collision that just sat down in a chair at home and is now having neck or back pain. Then there's long spine boards, and we'll talk briefly about those. There's your stair chair. That's a Stryker stair chair. There are other companies that make stair chairs as well. Here's a short spine board. Not something that we commonly see used around here. Most people will use a KED. Here's long spine boards, and again, there's a variety of different manufacturers who make these. Just be familiar with what you have in your service area. Some other types of stretchers that we have for carrying people include portable stretchers that may fold in half and are stored in a cupboard. Scoop stretchers, which are broken in half, a left and a right half, each half going under the patient and just scooping them up. Basket stretchers, which is what you would think. It's a basket that the patient fits in. Basket stretchers, or Stokes baskets, is a common one. These basket stretchers are used for high angle rescue. They're used for water rescue. Flexible stretchers essentially would be a canvas cot, Smith cot, a piece of heavy canvas with handles all around it, so people can slide that under a patient and just pick them up. And then vacuum mattresses. Vacuum mattresses are a mattress filled with foam beads, and you suck all the air out of the beads, out of the mattress, and the beads get closer and closer together and form or conform around the patient. It doesn't put any pressure or squeeze the patient at all. It just adheres to the patient and is somewhat more comfortable than a hard board. Here's a KED, Kendrick extrication device, and you'll learn to use one of these in class if you're not familiar with it already. Here is a scoop stretcher by Furno, where it splits apart into a left and right half and is used just to scoop the patient up off the ground. And this is fast becoming a preferred method of moving a patient from point A to point B. Here's your Stokes basket, or a basket stretcher, where a patient can be placed actually in the basket, suspended from pulleys and that sort of stuff for high angle rescue or water rescue. Here's a collapsible foldable stretcher. You can see it pivots right in the center. It breaks down right here, folds in half, and can be stored in a smaller area. Here's your vacuum mattress, where the patient is laid in a mattress and the beads or the air is all sucked out of the mattress, so it conforms to the patient's body. And were reported as being more comfortable than a hard board. How you choose the appropriate patient carrying device is based on local practice. There are some people that don't have vacuum mattresses, some people that don't use Stoke stretchers. So it really depends on what you have and what your medical director and service director like you to use. Patients who have spinal cord injury do need to be immobilized, and nobody is arguing that. If a person has suffered a spinal cord injury and has neurologic deficits, numbness, tingling, pain or paralysis, they need to be handled with kid gloves. But if they don't have those signs and symptoms, and they're not under the influence of alcohol or drugs, and they're a good historian and can speak your language, they don't need to be immobilized if they don't have signs and symptoms, regardless of the mechanism of the injury. And that's something else that we'll talk more about a bit later. An extremity lift is used to carry a patient to a stretcher or a stair chair. It can be used to lift a patient from from a sitting position. So here's an extremity carry. What you don't see here is if the patient were lying on the ground, you needed to pick them up and move them somewhere, you would both have to squat. Pick up, lock yourself in as they both have, and then stand up together. A direct ground lift is a way to lift somebody from the ground to a stretcher, and here's an example of that, where you take the patient and cradle them in your arm, pick them up onto your legs, and rest them there while you regain your composure, and then you just step forward and lay them on the stretcher. You can also use a draw sheet method and a direct carry method. Here's a draw sheet where the patient is on a draw sheet, and you're just going to put your ambulance cot next to the emergency department bed. Your ambulance cot is a couple inches lower than the emergency department bed. And you're just going to pull her over and slide her right onto your cot. The draw sheet method of direct carry is much like what you did on the previous slides from the floor. You're just going to scoop under the draw sheet, and carry her to the cot. Now, the American Heart Association and other organizations will talk about a recovery position, and this is also known as the left lateral recumbent position. And in this particular position, you're going to want to put a patient who is unconscious but breathing into this position. If there's no spinal cord injury suspected, by rolling them up onto their side, you're able to allow them that should they vomit, that they don't aspirate their vomit because they're lying flat on their back. When we treat somebody for shock, we don't lower the head, we don't raise the legs like maybe you'd heard or had practiced years ago. Those sort of things just really don't work. What's most important to treat a patient in shock is to keep them flat, and more importantly, to keep them warm. And that may be one of your random basic skills that you do in your EMT practical, is positioning a patient for shock. So you'll practice this as well. Transferring the patient to a hospital stretcher is something that you may have to do as well. So when you get to a hospital, you're going to have to move the patient from your ambulance stretcher to the hospital bed. And they do that with what's called a modified draw sheet method. And so here's an example of that. You've got your hospital employees on one side of the hospital cot. You and your partner are on the other side. You're going to grab the draw sheet that the patient is lying on, and on somebody's count, and you identify who that is, you all pick and move the patient up over to the ED cot. Now, you notice that the ED staff are extended initially on the pull, and the EMS providers are extended towards the end of the pull. So you have to be really careful during that period of time not to hurt your back. And then once the patient is moved on to the ED stretcher, then you certainly can assist in making them comfortable, elevate the head of bed, raise the rails on the bed to keep them from falling out, and give your patient report to emergency room staff. Okay, so that's all we have on lifting and moving. And again, it's a brief discussion. Most of this you'll learn by actually doing. So I would assume one of your labs would involve lifting and moving. If you have any questions, you know how to get a hold of me, or your site director does, and we'll talk to you soon.